Good morning. Good morning. Welcome, everyone, to the Harvard Medical School Osher Center for Integrative Medicine Grand Rounds this morning. So we hope you all had a wonderful summer. My name is Gloria Ye. I'm the Director of Clinical Research at the Osher Center. And I just want to thank you all for joining us this morning at our first fall session of the new academic year. So as you may know, the Osher Center is very fortunate to have a competitive pilot grant funding program where we're able to provide seed funding for 2 to 3 promising research projects each year that engage our community to collaborate together and move forward innovation in the field. So it's our pleasure today to have today's Grand Rounds showcase 3 of these recently funded projects and the PIs. So Dr. Ryan Mace, Dr. Michael Goldstein, and Dr. Abigail Batchelder. So I'm going to introduce each of the speakers before they talk, and then we will allow a brief 2-minute Q&A after each of the individual talks. At the end of each of the at the end of all 3 talks, if time allows, we'll then open it up again for questions to all of the 3 speakers. All right, so please use the Q&A function in Zoom to write in your questions at any time during the talks. All right, and I'll be able to take a look at those and pose them to the speakers at the end. Okay, so with that, let me introduce our first speaker. So the first speaker today is Dr. Ryan Mace. Dr. Mace is a clinical health psychologist and an assistant professor in the Department of Psychiatry at the Harvard Medical School and at the Massachusetts General Hospital Center for Health Outcomes and Interdisciplinary Research. His clinical research focuses on the integration of mindfulness, lifestyle behaviors, and technology to promote brain health in aging and medical populations. And he has extensive training in delivering evidence-based, integrative, and mind-body therapies to individuals, dyads, and groups across the health illness spectrum. He was awarded an NIA, National Institutes of Aging K23 Career Development Award to refine the My Healthy Brain intervention, for which he was originally awarded the Osher Pilot funding. And we have the opportunity this morning to hear about this project today. So welcome, Dr. Mace.
Thank you, Dr. Ye, for that introduction. I'll go ahead and share my screen. Can you see this okay? Fantastic. Well, thank you so much for the invitation to present at Grand Rounds. Actually was here a few years back before presented Grand Rounds prior to starting this project, and it's really exciting to return and share the results. And so my project is titled the My Healthy Brain Program, a novel mind-body program for promoting brain health through lifestyle change. And just briefly to tell you a little bit about my center, the Center for Health Outcomes and Interdisciplinary Research, directed by Dr. Anna Maria Vranciano. We develop mind, body, and lifestyle interventions across the health and aging lifespan. But I specifically focus on older adult and aging populations, specifically, as Dr. Ye mentioned, integrating mindfulness and technology to promote healthy aging and hopefully stave off cognitive decline and dementia. And I was very fortunate to be awarded an Osher Pilot Grant in 2020. It really kept me sane during the pandemic, and more importantly, led to my independent research program through an NIA K23 Career Development Award. About 40% or nearly half of risk for dementia may be attributed to various modifiable lifestyle risk factors, which is good news, given that that actually gives us something to maybe take some agency in protecting our brain health and reducing our own risk of cognitive decline and dementia. And based on epidemiological and meta-analytic studies, the main pillars of brain health or lifestyle factors that reduce risk for dementia include physical activity, sleep, adequate diet and nutrition, specifically the MIND diet or the DASH diet, which is the Mediterranean diet, increased mental stimulation and social activity with aging, and reducing unhealthy urges like excessive drinking or smoking tobacco. But like all of us, older adults struggle to start and maintain healthy lifestyles, whether it be stress or lack of time or resources, but specifically to aging populations, cognitive decline and early memory challenges can get in the way of lifestyle goals. Mindfulness is emerging as a promising avenue for promoting and sustaining lifestyle behavior change. And according to the mindful self-regulation theory, mindfulness may help with lifestyle goals in terms of raising awareness of negative habits, such as overeating when stressed or not going to the gym when we become overwhelmed with work. It may allow us to be more in the present moment and reduce autopilot to make and sustain intentional lifestyle choices. And specific to brain health, it may have some direct benefits. And there's lots of studies out there from the imaging and neuroscience world showing that mindfulness promotes stronger brain structure and a more efficient cognitive function. But it also helps with some indirect benefits, such as reducing peripheral risk factors for neurological illness, such as cardiovascular disease, chronic stress, and depression. And it also may help older adults cope with cognitive symptoms rather than catastrophizing about whether a memory lapse may be an indicator of something more serious like cognitive decline or dementia. And most importantly, we're finding that mindfulness is feasible for older adults, even with subjective cognitive decline or mild cognitive impairment. And this leads to the My Healthy Brain program, which I'm excited to share with you today. Mindfulness and cognitive behavioral therapy components really make up the core of the My Healthy Brain program. So when combining them, what this looks like is, for example, setting individualized lifestyle goals using the SMART framework, and combining that with mindfulness to stay on track, as well as some formal mindfulness practices that are related to lifestyle behaviors, such as mindful walking or mindful eating. And because the Osher Award came in during the COVID-19 pandemic, we had to, like everyone else, move our study to virtual. And so what we've combined is this mindfulness and CBT-based approach with patient-informed technologies, including using an activity watch like an actigraph or a Fitbit to track progress with sleep or with step count, as well as conducting the program entirely virtually via Zoom, as well as the cognitive assessments that we do at the beginning and the end of the program, with the goal of targeting these lifestyle risk factors that are most associated with dementia. And the long-term goal being to reduce the risk of dementia and cognitive decline. So we've been developing the My Healthy Brain program at MGH Choir iteratively over the past few years, following the NIH stage model, which is similar to the phases of pharmaceutical drug development. And the Osher Pilot funded the initial development of the My Healthy Brain program, which I'll be sharing about briefly today, with the ultimate goal of working toward a fully powered efficacy trial of My Healthy Brain to test efficacy for our primary outcomes of cognition and lifestyle, as well as some mechanisms of mindfulness for behavior change versus an attention pilot grant was a qualitative focus group study to develop and refine the initial My Healthy Brain program. We conducted 2 focus groups with 11 patients referred from the Osher clinical program. And these were older adults who were age 60 and over. They had some interest in lifestyle behavior change, and they had some early concerns about memory loss. And what we found were that there were biopsychosocial determinants to lifestyle change, that medical comorbidities or family history of dementia was a motivator for interest in a lifestyle program. There were a lot of barriers, including low motivation, difficulty planning, stress, anxiety, and depression that we needed to address in a program like My Healthy Brain. And of course, like many others, time, finances, and transportation also made lifestyle change challenging. There was high interest in mindfulness, people found that it was something that they either had prior experience with or interested in learning in a program like My Healthy Brain. But there were a few challenges, such as concerns about not practicing mindfulness right, or not being able to stop their thinking, which are very common for people practicing meditation for the first time. And contrary to the stigma of older adults not wanting to or being able to use technology, at the start of the pandemic, a lot of older adults were already familiar with Zoom, and therefore there was a lot of positive perceptions of completing this program virtually. And we published these results in Aging and Mental Health. And this prepared us for part 2, where we conducted a mixed methods virtual open pilot of the My Healthy Brain program. Older adults with the same eligibility criteria, so 60 and older, early cognitive decline, and then one or more of those lifestyle risk factors for dementia, were referred by the Osher clinical program. Our primary outcome were feasibility markers. Essentially, can older adults complete this program? Do they want to stay in the program? And do they enjoy the program? Otherwise, we'd want to make some refinements before conducting more resource-intensive, larger trials. But we were also interested in changes in cognition, lifestyle behaviors, and mindfulness mechanisms that we hypothesized. And essentially, at the study flow that you see down at the bottom, participants were referred virtually from Osher. They conducted baseline and post assessments virtually via Zoom in group or one-on-one settings in breakout rooms for the cognitive assessment. And we used the MOCA for this pilot study. And then during the intervention phase, the participants met with me in a group setting for 8 weekly sessions, 90 minutes each, in which they set individualized lifestyle goals. They wore an actigraph watch to objectively monitor and track their progress toward those goals. And then they learned mindfulness supported by in-session meditations, as well as recordings on our website that they could play back at any time. And after the intervention phase, they repeated the assessments, and then we did a group exit interview to learn what participants thought of the program. And as I mentioned before, feasibility was our primary outcome, and there's a lot of results on this page, but I hope to highlight that overall, we met our feasibility benchmarks, which was very promising that older adults could enroll, complete the program, and complete all the assessments and data collection. The one benchmark that did not meet our criteria was treatment expectancy. And it's not surprising that older adults may have been a little bit hesitant of whether they would benefit or see drastic or significant improvements in their memory or their cognition, given the expectation that dementia is neurodegenerative. So this is really important information for future studies to set expectations of what people may expect to benefit from a program like My Healthy Brain. We have a lot of quantitative results as well. Generally, we found medium to large effects in our cognitive and lifestyle outcomes. We did not find any effects for alcohol, diet, depression, anxiety, or social isolation, which indicates the need for some further tweaks to our intervention components or our measurements moving forward in future studies. However, we did find some promising effects with cognition, as you see on the left-hand side with the Montreal Cognitive Assessment, as well as decreases in self-reported cognitive symptoms. And I think most importantly, what really illuminates the program is what people thought in qualitative exit interviews. And we found strong and positive overall impressions of the program. People ascribed mindfulness to being its own reward. And this is something that many had said, even though they'd never practiced mindfulness in the past. And they started to integrate it with their lifestyle goals and plan to sustain practicing mindfulness long-term after the program. So in conclusion, the virtual My Healthy Brain was feasible and acceptable for older adults with early risk for dementia. And integrating mindfulness and technology is a promising approach for promoting brain health and lifestyle change with aging. And this sets the stage for the next study, currently in year 2 of my K23, which was informed by the Osher pilot, to further refine the program through qualitative interviews with medical professionals and providers within MGB to prepare for a feasibility RCT of the My Healthy Brain program. In the future, I plan to submit an R01 to test the efficacy of My Healthy Brain. and eventually tailor the program to underserved populations to address the vast disparities in dementia and brain health care, and hopefully scale this broadly using digital health technology. Thank you so much for the opportunity to present and the funding from the Osher grant. And we are currently accepting referrals to the next trial. So if you know any older adults that you work with, or in your personal life with early concerns about memory loss and interested in changing their lifestyle, please send us referrals. Thank you so much.
Thank you, Dr. Mace. Really exciting to sort of see where the Osher pilot funding was able to really jumpstart this project, and it's got its whole trajectory, ahead. Very, very exciting. I'm just going to take a quick look at the Q&A to see if we have any questions from the audience. There is one question. It's a quick question that from one of our, let's see, was Tai Chi part of the activity or program? That's the question. And perhaps, part of that is knowing that, Tai Chi as a mindful movement is quite popular among elder folks. So speak to that a little bit. Yeah.
That's a great question. I think it's a major limitation of the program. We did not include any movement-based mind-body practices. It was purely mindfulness meditation, more as in a seated practice, although we did have mindful walking, but it's something that we would love to incorporate in the future.
Great. Thank you so much. All right. So I know that there's going to be other questions out there. If folks can just save them for the very, very end so we can just get through all of the presentations. Okay. So I'm going to go ahead to our next presenter. I'm going to introduce Dr. Michael Goldstein. So Dr. Goldstein is co-director of the Behavioral Sleep Clinic in the Department of Psychiatry and a research associate in the Department of Neurology at the Beth Israel Deaconess Medical Center. Dr. Goldstein completed a postdoctoral research fellowship at the BI and Harvard Medical School and obtained certificates in clinical effectiveness and sleep medicine. In addition, Dr. Goldstein is also a licensed clinical psychologist in private practice who specializes in sleep and circadian rhythms, depression, anxiety, managing chronic health conditions, work-related stress, and life stage transitions, where he integrates mindfulness, breathing-based practices, and technologies such as mobile apps and wearable devices to tailor individual treatment plans. So he also previously served as clinical director for the BI DMC Division of Digital Psychiatry. Thank you so much, Dr. Goldstein, for joining us. Take it away.
Thank you very much. Yes, really thrilled to share these results from the pilot study. So even though what I will present is a small, circumscribed pilot study, it really was years of work also during the pandemic, and really took a whole team of collaborators. So and complementary to what I see from Dr. Mace's work in building the framework for a long-term research program, this really was a valuable opportunity to get into the elements of what's going on behind the scenes, both for doing the research and also for capturing some of the experiences and behaviors of participants doing these types of interventions. So to dive right into it, no disclosures. And I hope at the end of this that you will have a sense of preliminary data regarding the possibility of dismantling components of yogic breathing into mindfulness and the breathing specific pieces. However, spoiler alert, as a pilot study, very small N, we didn't do stats specific for these primary outcomes. So to just say that up front, that really what this will be focused on is how we can use heart rate variability to be used as a powerful proxy of breathing patterns. So a lot of these interventions, including Tai Chi that was asked in the previous presentation, a lot of them have these breathing pieces to it. And it's a big question. What is happening in participants' behavior in terms of breathing? How well are they adhering to these interventions? What's their experience with the breathing? So to give a lens into that, and then hopefully also be inspired to bring in some of these elements of the study design and data visualization into your own research. So may you be dazzled with colorful pictures, and be happy, healthy, and live with ease. And some of these pictures will have very small text in legends. So please email, and I'll be very happy to share a copy of the slides. And yeah, to dive right into it. So yoga as an umbrella term, in terms of how I'm approaching it here, is dismantling it into pieces of the breathing. And I see that as a structured rhythm. And for example, that could be a slow, continuous 6 breaths per minute, although there are many other forms of paced breathing or structured breathing as part of yogic breathing. And mindfulness, so some quality of mental activity with purposeful, intentional awareness. And just to recognize that posture and movement is a big part of many other yoga traditions. And one motivator for this was a study from Kromenacher et al., who is a good friend and colleague in grad school, and conducted this brilliant study. But I would say the title being yogic breathing didn't actually include this important quality of mindfulness. And so that led me to, want to really go further into this and see what's going on that might make a difference between having mindfulness intentionally integrated or just have a structured breathing alone. And also my dissertation study was looking at a very comprehensive yogic breathing program that was existing and already had some research on it, compared to a CBT-based program that didn't have as much of the mindfulness or breathing qualities to it, and to dig further into what was going on. Why does this matter? There's a relevance for just clinical care for patients, clients directly. May somebody be more motivated to practice mindfulness alone versus breathing alone? And so, and I can think of a lot of clients who maybe were reluctant about mindfulness qualities, but they would be very happy to do a structured breathing program. And so there's a lot of relevance just in clinical care. And then understanding mechanisms. For example, we could plot this on a conceptual matrix here and look at kind of a classic top-down, bottom-up component, as well as maybe more control-based or analytic-based methods versus acceptance-based approaches. And so we could see some of these components. Again, I'm focusing on these three: the mindfulness, paced breathing as the components for yogic breathing. How might these fit on that matrix? So to dive into the heart rate variability component here, we have a raw EKG waveform with the clear R spikes, and you can just visually see some of the variability between these R spikes, and we can convert that to the beats per minute heart rate across time, and we see this segment is actually 1 breath. As this individual is breathing in, the heart rate is speeding up, and breathing out, it's slowing back down. And so if we zoom out a little bit to a couple minutes, we can see this oscillation across time. And in the dark black is the breathing, or is the actual heart rate, and behind it is the breathing. And we can see that in phase, they align quite a bit. And this is referred to as cardiopulmonary coupling, or breathing heart rate synchrony, and a number of other names. And of course, the absolute heart rate may be changing a little bit, but their relationship in time seems to be constant. So breathing seems to be reflected in the heart rate variability. One way to quantify that is with spectral analysis. So we can see a complex waveform in time here, and then spectral analysis can break that into its constituent parts, into pure sine waves, to capture what are the prominent pieces. And so in this example, we can see in this waveform, if we were to really break it down mathematically, we see there's a faster frequency part, a slower frequency part, and something that's relatively in the middle. And then we can plot that across a power spectrum, so frequency by the amplitude. And to convert that to an actual recording from the pilot study that I'll present, so this is a preview to many more of these visuals, we can see in the top panel a time series of heart rate. And then if we zoom in, we can see that here is some more consistent breathing. This is just a resting breathing recording. And we can see that that maps onto a peak in the power spectrum. So this is the average power spectrum akin to this example here. This is for the whole recording. But then we can also look across time. And we see that, again, as we see in the raw signal here, this maps onto particularly a more consistent breathing pattern during this period of time. So heart rate clearly varies over time, primarily related to breathing, and we can really capture this dynamically with these types of visuals. So this is the framework for the rest of what I'm going to present. And we can see that this is an example, again, from that paper from Kromenacher et al., that shows where they asked participants to breathe within the 4 to 9 breaths per minute range. And the breathing rate corresponded to the peaks in the heart rate variability spectrum. We can see that more broadly. This is at different breathing rates from 4 to about 20. And we can see that the peaks really map on, again, consistently to the breathing rate. And then to anticipate a question about diving into 6 breaths per minute, what about holding the breath or other forms that still follow that 6 breaths per minute pattern? Generally, the peaks, so the frequency rhythm of breathing rate, seems to be very similar across these different forms of 6 breaths per minute. And we're going to focus, you'll notice that there's a couple of these peaks here. This is the primary peak, the largest one, that we're really using as the proxy of breathing rate. And these are some harmonic peaks, and we can just ignore those for the talk. And just to note, I would be very happy to expand on this in questions, but kind of a HRV research public service announcement. There are many different ways to capture heart rate variability. That's a large debate, and there have been really great presentations by Osher staff and faculty and many other colleagues. So the breathing rate, if it is basically in a certain range, then it can be clear of some of these methodological issues. This creates a conundrum for yogic breathing research. And in short, all of the data that I'll be presenting are presumably related to vagus nerve stimulation. So if we're thinking about that mechanism question, that they are really vagus and parasympathetic. So for the pilot study, we wanted to ask, could we, similar again to being conducted during the pandemic, could we use wearable technology, also a virtual lab visit format, and a dismantling type design to successfully carry this type of research out? And again, many collaborators on the study, and Dr. Huan Yang and Dr. Yan Ma were really vital to carrying this through as co-PI and also lead author on the publication that's open access, so you can access it there. So we had 18 participants and broken into these small groups, generally healthy adults with minimal prior yoga meditation experience, and randomized to one of these 3 interventions. And just some of the details there in a fully remote format. Again, we did virtual lab visits that had a lot of components on it, but I'm going to focus on the practice and some of those other pieces. And we really had great success with retention. So to just give some of those numbers there, and again, you can go to the publication for details. So overall, it was found to be quite feasible to collect the data. So in terms of sleep logs, a standard benchmark is getting about 70% data collection, and we well surpassed that. For practice, often this is a challenge in these types of interventions to have daily recommended practice. And we were really going for a benchmark of at least half of the days. And again, well surpassed that with about 75% of the days successfully recorded, both for heart rate and practice logs. And so these are just some example visuals of how we behind the scenes really looked at it in detail and captured it with the polar heart rate monitors and a third-party app, and then brought it into MATLAB and set up an automated method to analyze over 500 recordings in about 10 minutes. So just an example, without a supercomputer, just a regular computer, and some systematic work. So again, here are kind of examples to compare these spectra. And we can see just qualitative, visual, we can see some clear differences already in these breathing patterns. And now I'd like to go into it a little bit further. These were from the virtual lab visits, going across a few different recordings. So from a baseline and then a baseline again right before the practice. And we can see really clear differences in these recording profiles. And then this was a stress test and a recovery phase, and some other data here. So again, just an example of how we can really appreciate the richness of the data that we're collecting here. And the daily practice were also captured in such a detailed format and actually sent to participants. And we found that giving participants their data, which is, of course, it has a lot of trade-offs to it, but in a way that is appropriate with the integrity of the study design, really boosted motivation. And then we went really specifically into what were they doing during these daily practices. And we saw these clear patterns again that really seemed to differentiate participants who consistently adhered to the practice and had self-reported motivation engagement ratings on a 0 to 100 scale of just how motivated or engaged were you in this recording, as well as, to what extent were you distracted. And that really seemed to map on their subjective ratings with the behavioral recordings, and was a consistent pattern. So for all sessions, we see kind of a consistent trend in terms of what it looked like for each of these participants. And this really may be the most powerful visual, I think, looking at here, to really differentiate participants, as well as differences within a participant if it's a day where they're particularly motivated and a day when they're less motivated or more distracted and just juggling other things. And we can see here's one where somebody was following the slower breathing early on and then kind of faded out into resting breathing, and vice versa. So then, can we separate mindfulness and breathing? This is the question that's very exciting to try to answer. And it seems that the breathing practices did map onto the structured breathing. Mindfulness did seem to be associated visually with some increases in mindfulness self-reported scales. So the mindfulness and the combined group. And overall, there did seem to be some functional benefits from the interventions. So there's also a lot more data that are collected, and also some exit interviews as well that we conducted. Would be very happy to collaborate if other folks are interested in digging into these data. And I would also hope that they're, again, useful. Happy to share some of the methods and other details about how we did that. So really grateful for the whole team and for you all for listening.
Thank you so much, Dr. Goldstein. So I have some questions actually, but I think I might hold on to that. I'm just going to take a look at the Q&A here. Okay. I guess I'll ask a very, very quick question, and then we'll have to move on to Dr. Batchelder. But I guess I was wondering, in terms of, like, how can we, you spoke a little bit to this, but how can we really use all this detailed data, like all this, the characterization, that you, for each of the breathing types, how can we really use that to, I don't know, to better tailor or somehow make more specific, these interventions, for the patients?
Yeah, maybe if we brought in our machine learning colleagues and doing other kind of big data learning and an AI-based algorithms, artificial intelligence, to see what the have a more complex characterization of what these patterns are, and maybe even get at skill that's being developed over time. So does a practice session look more like this, or more like this? More like this, or more, versus this, and have some automated feedback and maybe even encouragement during a practice session, and even give nudges of, hey, continue with the breathing, and it was a really great first 5 minutes that you had. Maybe so to give some automated feedback live, that would, I think, really improve intervention and quality.
Yeah, fantastic. All right. Thank you so much, Dr. Goldstein. Let's just move on. So we make sure we give everybody their time. So I'd like to introduce Dr. Abigail Batchelder. Dr. Batchelder is an assistant professor in the Department of Psychiatry at Harvard Medical School. She's a staff psychologist and assistant director of the Behavioral Medicine Program, where she leads the Substance Use and Stigma Research Program in the Department of Psychiatry at MGH. She's an affiliated investigator at the Fenway Institute, and she's also the director of the Harvard University Center for AIDS Research, CFAR's Substance Use Scientific Worker Group, as well as interim director of the CFAR's Community Engaged Research Program. Her research focuses on collaborating with communities impacted by substance use, HIV, and minority stress to develop and implement interventions to overcome psychological, behavioral, and structural barriers to psychobehavioral treatment among minoritized people. Thank you so much, Abby, for joining us. Take it away.
Great. Thank you, Gloria. Thank you all for having me. And I just want to apologize in advance. I might be coughing a little bit. I actually have COVID right now, but I'm happy to be here and share a little bit about this work. Can you see my slides? Yes. Okay. So
I don't see your slides just yet.
Oh, you don't? Oh, okay. Hold on. Let me just share one more time.
There you
Do
go.
you have it now?
Yes.
Good. Okay, great. So I'm actually going to be presenting on something that's very different than what I usually do. You might note, based on the introduction that Gloria gave me and my various positions, I am an interventionist, and I primarily focus on health disparities. But today, and in this Osher Pilot trial, I focused on the measurement of negative self-conscious emotions. And I'm going to kind of lead you through the journey of why I did that, and where we are with this really initial work in this space that I do hope winds back to improved interventions for the populations that I am so invested in serving. So with that, I think that this project could not have happened without the amazing team that I had the opportunity to work with, including Dr. Paolo Bonato, who is has many skills, but one of them is what I've been calling a movement engineer, and he does a lot of machine learning and really amazing work, as well as Dr. Molly Rubin, who's a social psychologist and does a lot of work with nonverbal presentation of emotion. Doctors Judy Moskowitz and Peter Wayne have been wonderful collaborators on this, as well as Dr. Federico Parisi and Julia Coriani, who has recently joined the team. Jenny Shin, this project would not have happened without, as well as Grace and Kyrie. So thank you all for your work on this, and we continue the work on this project, and you'll get a sense of that as we go. So negative self-conscious emotions are social emotions. They're emotions like shame, embarrassment, pride is a positive self-conscious emotion. Guilt is another negative self-conscious emotion. And they're known to be particularly behaviorally influential. Shame in particular is an emotion that is known to elicit an avoidance response. So, I think we can all relate to the idea that when we feel ashamed, we feel bad about some part of ourselves or something, some aspect of ourselves, we might want to, run home and pull the covers over our head and not engage with whatever it is that's making us feel that way. And that can be particularly true if the shame is related to some aspect of oneself that may be stigmatized. So I work a lot with people living with HIV, with active substance use disorders, many of whom are unhoused. So shame is an emotion that I see quite a bit clinically, and I've worked in a K23 and an R1 now and an R34 to try to come up with interventions to address the negative ramifications of shame. And one thing that has become really clear to me and poses a big challenge is that these emotions are thought to be systematically underreported. And there's some cultural variability, but in the United States and in the cultural context in which I work, they do seem to be underreported, which makes them particularly difficult to identify and intervene on. So classically, the way we ask how much shame someone's experiences is we ask them in a self-report fashion, how much shame are you experiencing, or how frequently do you experience this? But this requires folks to be aware of their emotions, which many are not, willing to disclose their emotions, and able to accurately distinguish between the two. So for example, guilt is known to elicit a reparative response, which can be associated with healthier outcomes or outcomes that might be associated with better health, whereas shame is more associated with an avoidance response, or sometimes a desire to change the self or engage in some kind of transformative action. And affective science indicates that emotions are really not one thing. They might not be just what we report experiencing or feeling, but rather are a constellation, as Lisa Feldman-Barrett has written, and others, of a cumulative multimodal experience. So over the past, 7 years, maybe, evidence has been emerging kind of akin to the facial coding work that was done by Paul Ekman and others historically, that postures or certain body movements may be associated with negative self-conscious emotions. For example, shame has been associated with looking down, hunching your shoulders forward and caving your chest in. So what we might consider 3 postural movements. Negative self-conscious self-report, various measures outside of self-report have been investigated to some extent, including the postural movements, but also things like autonomic stress response and some others with I would say mixed results. So single modality evidence has not been great in terms of predicting negative self-conscious emotions, and we may need different strategies. Further, there are some more exploratory modalities that may in fact be useful. Looking at some of the depression literature and some other literature, we might conceptualize that speech quality, even narrative content, word selection may be associated with these things. So again, all signs point to a need for multimodal measurement of negative self-conscious emotions if we're going to better understand what folks are going through in order to think about intervening in an effective way. So what I really wanted to do is evaluate the covariance of multiple measurement modalities of emotion in response to narrative emotion induction tasks. So really do a social psychology type experiment and I had the benefit of working with Dr. Peter Wayne, who introduced me to Dr. Paolo Bonato, to think about using machine learning to do this in a compelling way. And then ideally wanted to compare responses to 3 narrative emotions, induction tasks across measurement modalities to identify any unique associations with shame compared to frustration and pride. And frustration and pride were selected because of the literature out there indicating certain key characteristics that we might think about differentiating from a response to a shame induction task. And then if the measurement modalities of shame co-varied, could we think about, are they distinct from frustration and pride? And could we think about looking at them in relation to self-care behaviors as a theory would hypothesize or would lead to a hypothesis? However, this was beyond the scope of an Osher Pilot grant, and it was also outside of my wheelhouse. As I mentioned, I'm an interventionist, primarily a health disparities researcher. So what I did is I pursued an Osher pilot study to really just set the groundwork, which is what we did. So to one, develop protocols for collecting, testing, and analyzing. We selected 6 measures of emotion within the context of 3 experimental emotion induction tasks, which I'm going to tell you about. And then 2, assess the feasibility and the acceptability of this. Would this work? Would people find it reasonable to engage in both the instrumentation and the data collection methods? And this was I wanted to test this in 30 people. And I work mostly with people living with HIV. The way I wanted to, the reason I wanted to collect this data and to think about the findings was to inform HIV-related intervention strategies. So this was 30 people living with HIV. And finally, explore novel analytic approaches, including machine learning techniques, to assess the covariance of 6 measures, to assess emotions and to differentiate emotion measurement between 3 emotion induction tasks. So as probably all of you know now, it's very much in the news, and it's certainly buzzworthy, but machine learning is a branch of AI, or artificial intelligence, based on the idea that systems can learn from data, including identifying patterns. As I mentioned, Dr. Paolo Bonato is expert in this, and he and his lab have been wonderful collaborators in this project. And for this, we only had 30 people, so all of this is very exploratory. The goal was really to see if we could do this in service of a larger project to really use machine learning in the future. So we selected 6 measurements or modalities, if you will, of measuring emotion for this pilot trial. The postural movement, which I'm going to tell you a little bit about in a moment, is absolutely the most in-depth of what we've done and what we're still working on in many ways. The data is very rich and has many layers. But the postural movements, I would say, is the most novel and is leveraging the existing science. We looked at facial movements using Face Reader. Some of you may be familiar with facial action coding or FACS coding, which I'm going to go into greater detail in a moment, but identifies the movements of the face associated with emotions in some literature, autonomic stress response, vocal characteristics, narrative content, and self-reported emotion. And just to go into a little bit more detail, the way we are analyzing postural movements is using Paolo Bonato's lab and his postdocs at Spalding, essentially identifying the way the body is moving in space during these emotion prompts, which I'm going to tell you a little bit about in a moment, and then looking at like degrees of movement and change in response to these prompts. Facial movement, as I mentioned, we used Face Reader, so it's essentially a combination of muscle movements in the face that have been associated with various emotions in the literature. We measured ECG and galvanic skin response using Empatica monitor, also from Paolo Venato's lab. And we are also looking at vocal characteristics. So we recorded speech during everyone's narratives, which I'll provide a little bit more detail about in a moment. But in addition, we had the opportunity to look at loudness, speech features, essentially loudness, pitch, intonation, sharpness, etc. And then narrative content. So we've transcribed all of the content that folks provided in response to the prompts, which I'm going to tell you a little bit more about in a moment. And then finally, we asked self-reported emotion, which is, again, the classic way of measuring emotion at this time. So we use the palms, select how you feel right now. Okay, so the actual prompts looked like this. So, and maybe I'll just scroll here for a minute. So the study and design that we came up with, working collaboratively with this team, is we asked everyone to come into a very orchestrated room. There were 3 cameras that we set up, 1 in front and 2 on the sides. And everyone sat with their feet in a specific position on the floor facing a computer screen, and we recorded 33 minutes of silence to get a baseline. And then we had 3 emotion induction tasks, which I'll share a little bit more about in a moment. And then between each of those, we had a washout task, which I'm happy to share a little bit more about as well. And then we ended everyone on joy. For the first 3 that we were actually measuring, the shame, frustration, and pride, were counterbalanced for order. The order was different. We ended with joy, just so no one left the office talking about shame or whatnot. But the narrative prompts themselves were essentially, tell us about a recent experience that made you feel a certain way. And we base this on some of the affective science literature and expert feedback from our team and outside of our team. And we asked everyone to tell us the story, and we had specific additional prompts with the beginning, middle, and end. Tell us how you felt in your body, and etc. And the content lasted between, I would say, 3 and 10 minutes for each of these. So the procedures were very carefully constructed. These are some images of myself as we were setting up the space. This was beyond anything I had ever done before in terms of data collection. And we had very detailed data acquisition protocols and protocols for pulling all of the data, combining the data, and aggregating them to look at the covariance. And really, I would say foremost, to see if this could be, if this was considered feasible and acceptable for a larger project moving forward. So in terms of the sample, everyone was 18 or older, English speaking, HIV positive, able to provide informed consent, and willing to provide their HIV related health records and prescriptions information, which is consistent with our general protocols. This is what our sample looked like. So we were able to collect data from 30 people. There were some challenges that I'll share with you in a moment in relation to feasibility, particularly given that this was happening during COVID and we were recruiting folks with who were immunocompromised, and there was no option to do this virtually. But this is who we got. So you can see the mean age was around 60. The majority were non-white. The vast majority identified were male, and sexual minorities, consistent with the population of people living with HIV. We had quite a range in terms of education. The sample was low income in general, and mostly single. So in terms of feasibility and acceptability, which were truly our primary outcome variables for this very early project, to figure out if we could even do this, I I would say in terms of feasibility, it took a lot longer to collect the data than we originally anticipated. We could not start when we were ready to start because of COVID. And then once we did get started, we had bouts of time that we could not bring anyone into the office. I would say that we were very conservative in that regard, given that we were recruiting folks living with HIV. Additionally, the training level that was needed to handle and work with the data that we were able to collect in this project really caused some additional delays in relation to folks leaving. So we would have interns who then had to move on, who had gone through quite rigorous training procedures. So we had long gaps, I would say, in our ability to work with new incoming people, given the nature of the data and the complexity of the procedures that we needed to utilize to really look at what we wanted to look at. Remarkably, I would say we only lost data from one person during the data acquisition process. As you can imagine, we have lots of data related procedures, both before, during, and after each participant came into the office. And we did lose one set of data from a person who did come into the office. Acceptability was a real question for me. I was not sure if folks would feel comfortable with this. It was very much, there were lots of cameras on an individual telling these stories about emotions and their personal experiences. But that's not actually what we found. We found that folks found it very acceptable and they felt very comfortable. I would say out of the 30, well, the mean is 9.67 on a scale of 0 to 10, 10 being very acceptable. Actually, 29 of the people reported a 10, and similarly for comfort level. So it was not the case that participants found this uncomfortable in any way, which was heartening to me, as I'm very interested in pursuing additional work in this area. Okay. So I'm running out of time. My apologies there. So in terms of the exploratory results, there's a lot more to provide. So I'm just going to give a very quick snapshot. But essentially, some of the results in terms of the full covariance matrix are pending. But the general gist is that we didn't find uniquely solicited emotion, but rather clusters of emotion. So I'm just going to kind of speed through and show you. So for example, in the self-reported emotion, following the intervention, the interview prompts, you can see the means here, and you might recall the range is 0 to 4 on the POMS, the way we solicited self-reported emotion. But so you can see shame, folks did endorse higher levels of shame, but it wasn't the highest in terms of what they were endorsing in response to the shame prompt, similar to frustration, pride, and joy. And that's really what we saw across. So there was some variability, but we did see clustering of consistent emotion. Oh, okay. And similarly, that's very much what we found in the face reader data as well. So in terms of next steps, we are continuing to kind of mine this data and work through it, working with our machine learning colleagues, and thinking about next steps as this was deemed feasible and acceptable. And I'll wrap up there. I'm happy to answer any questions or back channel respond to anyone about it.
Thank you so much, Abby. We've got many well wishes actually in the chat for you, and thank you again for doing this presentation while you're ill. We didn't know that before this morning. So we've run out of time. However, I do want to get in just one question for you, and that was a question regarding whether you suspect the environment might make a difference in the participants' experience in terms of your testing in that sort of experimental environment versus a more natural environment.
Is that for me?
Yes.
I think, yeah, it may have very well contributed to their responses. I think that is hard to know. What we were looking for is data on what might be useful in the context of a clinical interaction, which may be kind of similar to an experimental context. So, but remains to be seen. Additional work is absolutely needed.
Okay, wonderful. I would love to actually ask some more of these questions back to, there was a couple other questions for Dr. Mace, but I think, Dr. Mace, you've been responding to some folks, within the chat, and if you want to allow I think they're asking for some contact information, through the chat, and you can speak offline. My apologies that we won't be able to go back to the panel for more Q&A. So I'll just, sort of give my outgoing remarks again to thank all of our speakers today for their, for showing us, what they can achieve, with the Osher Pilot funding. I'm very grateful. So I have 4 very important announcements before we get off the screen here. The first is that we're actually accepting letters of interest for the Osher Pilot grant fundings for this next cycle. It just opened a couple days ago. So the letters of interest are due on January 15th, but we're accepting them all through the fall. The second announcement is that in just a couple weeks, September 18th to 19th, the Osher Center will be hosting the 2-day Science of Tai Chi and Qigong conference here in Boston at Assembly Row. So don't miss this inaugural event. It's going to showcase the state of the science of Tai Chi and Qigong, timely topics related to mind-body movement practices and as whole person health, exciting future directions in the field, and sort of how can we implement this in contemporary healthcare. So you can go to osherscienceoftcq.org for more information and registration. The third announcement is that the Harvard Medical School Research Fellowship in Integrative Medicine, funded by the NCCIH, our T32 fellowship, is also accepting applications, and they're actually due October 6th, so just in 1 month. So if you are interested, you have questions, you can feel free to reach out to me directly, as I direct the fellowship. And you can find info and applications at oshercenter.org/fellowships. And then last but not least, the final announcement is that next month's Grand Rounds is at a different time than usual. So it's usually the first Tuesday of the month, but next month it's going to be on October 10th, which is the second Tuesday of the month. And it's going to be at 12 p.m. Eastern time instead of 8 a.m. And we're going to be hearing from Scott Haldeman, who's a doctor of chiropractor, DC, a doctor of chiropractor. His talk is entitled Primary Spine Care, an initiative to address the extreme health burden of spinal care. So please don't miss that. And again, it's at a different time, October 10th at 12 p.m.